Good morning, dear colleagues. Are you listen me? Так, I'm here. I hope now you can connect to lecture. Now I upload video. Dear colleagues, now we start our lecture. Just a moment. Так, I hope now present. Hope now present picture. Now I check video. Not so many light, in my opinion, not so many light. Так. Dear colleagues, now quality of sound and quality of video enough? Dear colleagues, I ask you, are you listening me? Are you see me? Are you listen? Are you see me? Quality of picture, quality of sound, enough? Так, okay, very good. Now we start our lecture. Так, now I check my picture. Okay, now I see my picture. Так, let's go. Let's go, dear colleagues. Okay, today, my opinion, we has some short lecture. First part of our lecture, it's a disorders of perceptions. Today we will discuss about psychopathology. And today we will discuss about pathology of summary. Okay. Disorders of perception. I am Professor Alexander Dvirsky, Psychiatry Department. Okay, all of informations which we receive from surrounding. We receive informations via our sense organs. Some informations we receive via our inner receptors. Some informations we receive via our via our extra receptors. I hope you understand. Intra receptors register body conditions, and extra receptors register environment around ourselves. In general, receptors register energy and transfer informations to the terms of the nerve systems. In psychiatry and in psychology, we discuss about sensory processing. Usual sensory processing for education purpose we split to the two classes. First part, it's sensations. What does mean sensations? Sensations, it's a register of the elementary properties of stimulus, such as brightness, such as like sweetness, level of salt, level of acid, hot, warm. Due sensations, our brain receive data sensory of data from different channel. It's clear. It's a data without processing. It's a only stream of data. Second type of sensory processing, it's a perceptions. Perceptions, it's a cognitive functions. What has been perception? The detections of the more complex properties of stimuli, included its location, nature, involves learning. Perceptions, it's a cognitive functions. In sensations, in perceptions, we recognize word. We understand every image. We understand what we can do with the image. We understand how to use image. During perceptions, we categorizing. Because perceptions, it's a very complex operations. Because when we speak about learning, we mean then we speak about cognitive operations. What does mean cognitions? Cognitions, it's a connections between everything in our brain, in surrounding. Clear? In your brain, present mental process. Mental process, I repeat once more, subjective producer. For example, your imaginations, it's mental process. Your emotions, it's a mental process. Your face expressions, it's a behavior. Clear? Your behavior objective for me. Your mental process objective only for yourself. I understand your behavior via looking glass of your behavior. I understand your mental process via looking glass of your behavior. It's clear. Okay, perceptions. Perceptions possible with signal and without signal. Where situated perceptions? In general, perceptions situated in our short-term memory. When we think about something, this information persists in the short-term memory. Other names of the short-term memory, it's operation memory. Okay, now you understand. Then sensations consist of two parts. First part, it's only receiving signal from surrounding. Second part, it's a more complex, involving learning. It's a cognitive process which has name perceptions. This is sensation possible only with signal. Perception possible without signal. Perceptions involve all our mental ability, involve our memory, involve our thinking. And I repeat once more, it's very important. Sensation possible only with signal, perception possible without signal. When we discuss about sensations, we discuss about processing of signal, because in perceptions signal are possible absent. Okay, what's happened during sensations? First stage in sensations is the transductions. Where happen transductions? In our receptors, in our sense organs, in extra receptors, in intrareceptors. It's eyes, ear, vestibular sensors, our taste, our nose, our skin, internal or inner organs. Clear? Everywhere. Who do transductions? Receptors do transductions. Second stage in the sensations, it's a temporal coding. It's operations in which receptors coding properties of signal, like brightness, like darkness, like temperature. Clear? Different temperature, different ratio will generate receptors. I pay your attention. Receptors coding signal. Receptor don't only show present symbol or absent signal. Receptors create a properties of signal, like a level of signal. Clear? And last stage, it's an anatomical coding, like a special area of brain responsibility for the special feelings. Now more detail about transductions, anatomical and temporal coding. What has been transductions? Transductions is a process by which the sense organs convert energy from the environment event into neuronal activity. I repeat once more. Transductions, receptors do transductions. It's clear. Temporal coding. Temporal coding. The coding information in the terms of time. It's mean a ratio. For example, very hot, it's a 5 hertz. Not so hot, very cold, it's a 1 hertz. Clear? It's a different temperature in receptors, different ratio. Anatomical coding. It means by which the nerve systems represent informations. Different features are coding by the activity of the different neurons. In general, anatomical coding has a very strong connections with brain mapping. Special area of brain responsibility for the special part of brain. Like we detect when we see something, it's activity of the occipital lobes. When we listen sound, it's the activity of the temporal lobe. When we touch something, it's a percentual gyrus. And in general, you learn this topic in anatomy and physiology department. Now you understand what does it mean, for example, sound. Sound, it's activity of the temporal lobe. What does it mean, visions? It's activity of the occipital lobe, clear? And you must remember that reality absent, present only activity of the neurons. Activity of the neurons in our brain create word for ourselves, clear? I repeat once more, word absent, present only reflection of the word in our nerve systems. What does it mean? What's different between sound and vision? Sound and vision, it's activity of neurons. When we understand sound, when we understand what we see, it means that present activity in the visual cortex, present activity in the auditory cortex. But what's different between, from anatomical point of view, physiological point of view, it's a very same process. But in our consciousness, in our responsibility, it's absolutely different process. Why it's happy? Because different area of brain reflect in our consciousness like a different modality. What does mean a modality? It's a channel, like a visual channel, like an auditory channel, tactility channel. Now we discuss about about pathology of perception. I repeat once more: perception possible without signal, possible with signal, possible without signal. Misperceptions or misinterpretation of the real external stimuli, it's a illusions. Illusions, it's a not pathology, it's clear. It's a misinterpretations. For illusions, we need a signal. I pay attention. Sometimes it's not pathology. Cause of illusions. Due physical or environmental. Due physiological. For example, physical. A spoon in glass looks like a cracked. Why it's happy? It's happy because different. It's a reflection. Yes. Physiological properties of the sense organs. Sometimes we see something like a difference. Yeah. Due physiological state of the person. For example, we wait somebody and some noise we recognize like somebody coming. It's physiological illusions. Now about some words about hallucinations. I pay attention. Hallucinations, it's absolutely pathology. What does mean hallucinations? Hallucinations, it's a represent of image which absent in reality. I repeat once more. Hallucinations, it's a represent of image which absent in reality. Why hallucinations? It's a pathology of perceptions. Because you remember, perception possible without signal, possible with signal, possible without signal. And as a result, I hope now you understand. And if signal present but patient recognize signal wrong, for example, patients see to some object and recognize other object, it's illusions. When patients, if signal absent but patient listen something, see something, it's hallucinations. Hallucinations possible in all modality. It's mean visual, auditory, olfactory, gustatory, tactile, mixed or inner modality in inner organs, like special feelings in inner organs. Now this chart explains pathology of hallucinations. Pathology of hallucinations. Oh, sorry. What's different between hallucinations and illusions? Yes, illusions, it's a pathology. Illusion possible, not pathology. Hallucinations, it's absolutely pathology. Stimulus in hallucinations, absent in illusions, present. Patients feels like a real image. In both situations, I pay attention. For patients, it's a reality. Hallucinations, it's a reality for patients. It's a reality. And illusions, it's a reality. Patients usually not recognize, then he feel mistake, then he feel something mistake, clear? Yes, of course, now I use terms feelings. Why I use term feelings? I use terms feelings because patients, it's perceptions, it's a mental process. Mental process, I hope you remember, it's a mental process, objective for yourself, only for yourself. How to describe hallucinations? According of complex. It's elementary of complex. What does mean elementary? Elementary, it's mean like a noise, like a zzz. It's make like a sound flashing. Complex image, like a patient see somebody in rooms. It's a complex hallucinations. Yeah. According to the sense modalities, I hope it's understand auditory, visual, factority, tactile or deep, like some feelings in sense organs. I repeat once more. What does mean hallucinations? Hallucinations, it's a pathological activity of maybe of the neurons in the nerve systems, in the CNS. But possible it's a self-activity of the receptors. Maybe it's a activity, maybe it's something wrong between receptors and CNS. According to special features like auditory, second or third person, like a patient listen voice, which discuss about you. Visual, extra compile, like a patient said, I see something behind myself. Autoscopic hallucinations, it means patients see something inside inner organ. And last stage, the pseudo hallucinations. Pseudo hallucinations, it's a hallucinations in which image not so true. But why pseudo hallucinations very important in clinical diagnostic? These hallucinations very important because patients, because pseudo hallucinations very often we can linking to the schizophrenia related disorders. Like name of hallucinations: visual, optical hallucinations, auditory hallucinations, yes. Other type of hallucinations, gustatory. It's like a medical terms which you can use in your medical practice. I hope this picture clear for you. Now pseudo hallucinations. What does mean pseudo hallucinations? Pseudo hallucinations, it's a special class of hallucinations. Why it's not a true? Because true hallucinations for patients is like a real image. Pseudo hallucinations, it's not a real image for patients. It's not a real image. Patients has feelings like somebody does these hallucinations for him. Patient thinks and hallucinations not so clear. Maybe he feel hallucinations like inside mind, clear. And it's artificial. It's not, if usual hallucination patient said, I listen voice behind the door. Pseudo hallucinations patient said, I listen voice inside my mind. Somebody do use a special device and broadcasting this voice in my mind. It's a pseudo hallucinations. Sometimes distance, not in real distance, like a voice from space, voice from other country, something like this. Usual hallucinations, voice behind the door, voice from those directions, clear. In this type of hallucinations, like a pseudo, not real, something not real. I repeat once more. Usually these hallucinations accompany with schizophrenia related disorders. Usual hallucinations accompany with somatic and general practitioner problems, with somatic problems. In this picture, I explain what's different between hallucinations and pseudo hallucinations. Image locations, yes, it's like hallucinations in surrounding, in sense fields, in sensory fields, and pseudo hallucinations, not in sensory fields. It's maybe inside patients, maybe so far from patients, clear. Image quality. Usual hallucinations, image very clear. Pseudo hallucinations, not so clear. Reality of image. In hallucinations, image very real. In pseudo hallucinations, usual patient said that somebody do this image for him. It's not a real voice. It's somebody use special device and inject voice inside mind. Clear. like interpretations of the hallucinations. Etiology. Hallucinations usually it's due general medical conditions, but possible in schizophrenia, possible in epilepsy, a lot of etiology. Pseudo hallucinations usually it's a schizophrenia related disorders. It's mean schizophrenia, schizoaffective disorders, schizophreniform disorders. Thank you very much for your attention. I am Alexander Dvirsky. Dear colleagues, it's not a finish of our lecture. Now next topics. Today I show next some brief lecture in same time. Okay. Так, now I upload next presentations. Now I am upload next presentations. Just a moment. Now next lecture. Now I upload next presentations. Так, next lecture. Now I switch off my sound. Так, we continue our activity. Our next lecture it's disorders of memory. Так, dear colleagues, today during the lecture I want do something like a small briefing. Not so many students on the lecture, I see. It's a pity. Okay. Так, dear colleagues, not so large activity on the lecture, and for improve our education process, I pay your attention. I be increase numerous of questions and increase volume of test, because you don't want it's yes, of course, I pay attention. This briefing don't touch students which present on the lecture right now, but I explain why I do programs more and more difficult, because not so many students in our lecture. Okay, now we continue our lecture. Так, I hope picture present. Disorders of memory. I am Professor Alexander Dvirsky, Psychiatry Department. Memory. What does mean memory? Memory is a cognitive process of the encoding, storing, and retrieving information. Dear colleagues, I repeat once more these definitions. Memory is a mental process. First, what does mean mental process? Mental process means that it's a process which true and objective for yourself and subjective for other person. Other person cannot have not access to your memory. Other person has access to only to your behavior. And yes, of course, via looking glass of your behavior, possible receive some information about your mental process. What does it mean memory? Memory, it's a mental process. It's a cognitive process. What does it mean cognitions? Cognitions, it's ability to create connections between a different event. When I speak about event, what does mean event in our mind? Event in our mind, it's an activity of the neurons in our brain. From anatomical point of view, from physiological point of view, voice, visual picture, it's the same things. Different only locations. When we listen voice, it's activity of the temporal lobe. When we see picture, it's activity of the occipital lobe. When you close your eyes and dreaming about something and speak with somebody in your mind, it's activity of the other area of brain. Clear? Okay. Memory consists of three parts. Yes, it's first it's encoding. After that, storing and retrieving. Cognitions, cognitive element present in all stage of memory. What has been cognitive element? Now I try to explain for you. Now nobody think about pink elephant, but now you think about pink elephant. Before my sentences, pink elephant, nobody think about pink elephant. Now I use terms pink elephant. I said pink elephant, and everybody has some imagination in our mind. What does it mean pink elephant? What does it mean pink? What does it mean elephant? And it's a cognitive element of memory. When you catch something via your sense organs, your cognitive systems retrieve from memory pink, retrieve from memory elephant. I hope it's clear for you. Yes, now you understand what does it mean. Now we will discuss about stage of memory. First, like a stage, initial stage, it's encoding. The process by which sensory information is converted into the form that can be used by the brain memory systems. I pay your attention. Not only sensory information. You must understand. When storing in our memory some idea which we create in our brain. Clear? We do something in the brain and we storing this information into the brain. Clear? Not only surrounding event we storing into the memory. In our memory, we can storing all kind of mental process which happen in our memory. Usually, we storing in our memory not only means of event, we storing in the memory like our emotional relations, our emotions about emotional color of this event, we storing into the memory. Storage, the process of maintaining information into the memory. I hope you understand. But it's a process in which we put information into the memory. Very important understand. Very important understand. Then storage. Memory, it's not a storage. It's a mistake. Memory, it's a cognitive systems. It's mean every information which we put into the memory has some meta element, and this element has connections with other element. In general, we put in our memory only elements which has a positive emotional color, which do something positive for ourselves. It's maybe experience, it's maybe some image, it's maybe like some cheats, clear, life hacks, like everything's clear. In general, we storage put in memory informations which useful for ourselves. We put in memory informations which we use very often. Informations which we don't use very often present in our memory, but access to these informations not so easy. For example, during the class, you manipulate with informations about class materials very easy. After some weeks, you with problems manipulate with these informations. Why? Because informations, memory is a cognitive systems. Our memory has more easy access to informations which we use more often. Clear? It's very important. How to be a doctor? You must every time reading medical books. You must every time reading medical video. If you every time watch video about crime, about detective movies, you be a detective. Clear? Our environment create our internal worlds. Retrieval. It's an active process. We extract from memory informations which useful right now. Nobody think about pink elephant right now, but now you once more think about pink elephant. Why you think about pink elephant? Because I start speak about pink elephant and your cognitive systems every time retrieving informations about pink elephant. And if I start speech with other topics, for example about, I don't know, about, for example, Alzheimer diseases. Yes, now I use terms Alzheimer diseases, and from your memory you derive informations which touch Alzheimer diseases. Maybe I use terms amyloid. Maybe now you retrieve informations about connections between amyloid and say so, and Alzheimer disease. Maybe now you do connections between memory topics and Alzheimer diseases. Yes, because favorite symptoms of Alzheimer diseases it's amnesia. Other classification of memory, like a stage of memory, type of memory. First type of memory, it's sensory memory. What does mean sensory memory? How understand what does mean sensory memory? It's very easy. Now you see a picture on your screen. Close your eyes and very brief times you will see picture. After that picture be destroyed. And when you see picture, when you open eyes and once more see picture present in your sensory memory. When you close your eyes, less than 1 second, picture present in your memory. After that erasing. Why it's happy? Because sensory memory user very brief. When you listen my voice in your sensory memory. When I stop speak something, you lose my voice. Why it's happy? It's happy because sensory memory very brief. But sensory memory input very high quality informations. Very large, very high capacity, and very brief. HD sound, say so. HD picture. Okay. Short-term memory or operation memory. In this memory, we manipulate with perception image. I pay your attention. Perception image living in the short-term memory. Short-term memory, it's a windows to our memory. It's a windows to our consciousness. Short-term memory, it's a windows to our awareness. If something present in our short-term memory, it's informations, we understand these informations. Clear? How many objects we can put in the short-term memory? In the short-term memory, we can put near the 7 objects, maybe 5, maybe 9, maybe 8. Clear? And we manipulate with this image. But it's not a bit like in computer. It's like an elephant, it's like a dolphin, it's like a psychiatry, it's like a schizophrenia, it's like Alzheimer disease. Yeah, I think now I use elephant, dolphin, Alzheimer diseases, schizophrenia. You're automatically categorizing. Two, it's a Emily, two, it's a main name of diseases. Clear? Your brain automatically manipulate with image. When you listen my speech, you split my speech to the 7 objects. You can manipulate only with 7 objects in same times. Yes, of course, if you listen to me and listen as a person, sometimes you listen to me, sometimes you listen as a person. Why it's happy? Because phrase, sentences, usually it's the same words. You are gonna, for understand means of my speech, you must put same words in your short-term memory and organize and like extract juice of means from my speech. Clear? When you listen your colleagues which sit down in your rooms, yes, of course you listen as a person, but my voice like a background without means. My voice have not means when you listen as a person, because 7 register in the short-term memory now visit you as a person speech, and not enough capacity for my speech in your memory. How long time persists information into the short-term memory? Near the 30 seconds. What does it mean? When you refresh information into the short-term memory, when you think about something, information persists. If you 30 seconds don't think about something, this information is erasing from the memory. Long-term memory. Long-term memory has very large capacity. Information persists permanently or near permanently, but we don't know what's happy in our long-term memory. We can check only our long-term memory only via windows of the short-term memory. Clear? Like I see to your screen via small windows. Clear? Now I see to my screen via small windows. Now I see only phrase stage of the stage memory, and I don't see other text. Clear? You like rolling in large storage, and you have very small windows, like situations for you how to understand the situation. It's mean you have very large storage, and on the roof present very small windows. From windows you see only very small part of the storage. When you rolling these windows or visit other windows in the roof, you see other part of storage. Clear? Informations when we retrieve from long-term memory, it's information which useful right now. It's a cognitive systems. Clear? It's a cognitive systems. Now conditions which can develop problems with memory. First, yes, of course, it's a neurodegenerative diseases. Due maybe protein problems, maybe blood vessel circulations, like it's maybe vascular dementia. Yes, in general, 2 main problems with memory. It's Alzheimer and vascular dementia. It's maybe more than 75%, maybe much more. Other problems, it's from same volumes, it's other problems. Okay, other problems, it's alcohol problems with memory, Korsakoff syndromes, Wernicke and Korsakoff syndromes. It's like a next after Alzheimer and vascular dementia. Next, it's trauma. Surgery, encephalitis, cerebrovascular disorders. Yes, it's yes, of course, cerebrovascular disorders. It's kind of neurodegenerative disorders due vascular problems. Other examples may be systematic diseases, tumor, like metastasis. A lot of problems can developing problems with memory. Name of the disorders of memory, it's amnesia. What does it mean, amnesia? Amnesia, it's problems in memory in general. Yes, it's when patients cannot remember something. It's like something patient cannot use memory. It's not mistaken memory. Mistake in memory, it's a paramnesia. If patient something forgot, not retrieving from memory or cannot put in memory, does not matter. Something absent in memory, it's amnesia. Anterograde amnesia. It's now we speak about like a traumatic event. It's like frontiers, like something if patients don't remember which happened before. before start problems, traumatic event, it's anterograt amnesia. For example, trauma, and patient don't remember why he has this trauma. It's mean anterograt amnesia. Yes, in Alzheimer's disease, patients don't remember of an address. It's anterograt amnesia. Retrograde amnesia, next type of amnesia. It's retrograde amnesia. Retrograde amnesia, it's mean then patients don't remember something after traumatic event. Main causes of it's a Korsakoff syndromes, it's neurodegenerative disorders, it's problems with metabolic problems. Other very interesting causes of amnestic disorders, it's seizures. We remember something when we in consciousness. When we have not without consciousness, we don't remember anything. It's clear. Our memory, it's like a films, which it's like a films of consciousness. It's a films of consciousness. Absent consciousness, we anything storing in our memory. Clear. A lot of problems can developing problems in memory. Clear, a lot of problems. It's but main groups. It's infections. It's neurodegenerative disorders. It's brain lesions. It's vascular problems in the brain. Hypoxia. Yes, a lot of problems. Electroconvulsion treatment, very interesting. Yes, due ECT, patients remember has anterograde amnesia, and as a result, patients don't remember what's pain due treatment, due procedure. Clear. This procedure not so dangerous for patients. Why? Because patients don't remember pain. Thank you very much for your attention. I am Alexander Dvirsky. Так, dear colleagues, stop. Now I check maybe other lecture today. Just a moment. Don't present in. Okay, for today enough. Thank you for your attention. I hope you remember today we has a class. Yes, today we has a class. Okay, goodbye. Так, dear colleagues, stop. I see we has lot of time left. Just a moment. Maybe I show other brief presentations. Oh, other very brief presentations. Так, нет, stop. Maybe I show other very brief presentations. Так, Так, other presentations today, tic disorders. Now other presentations, tic disorders. Now I don't understand why it's absent. Так, other topics, maybe tic disorders. Now we discuss about tic disorders. Tic disorders and movement disorders. I am Professor Alexander Dvirsky. Tourette syndromes and tic disorders in DSM-5 classifications. Tourette disorders, chronic motors or vocal tic disorders, and transmit tic disorders. It's an etiology of the tic disorders. Clear? It's a tic. Today we will discuss about tic and about other motor disorders which need differential diagnostic with tic disorders. Clear? Okay. Now you remember. Then usually we can meet tic disorders during Tourette disorders, chronic motors or chronic motor or vocal tic disorders, and transient tic disorders. It's a name of diseases. Clear? It's a name of diseases. Tic, it's a syndromes. It's a name of diseases which include tic-like favorite symptoms. Now abbreviations which we use in our lecture. Tourette syndromes, obsession compulsion disorders, attention deficit hyperactive disorders. What does it mean, tic? Tic, it's a stereotyped, coordinated movement of movement, vocalizations, or mimic regular behavior. Dear colleagues, what does it mean regular behavior? It means this activity persists very often and accompanies some other activity. For example, patient tries say something and do something like this. When he think and feel some distress, for example, he do some activity. Clear? Voluntary. Stereotyped. It's a stereotyped behavior. Tic, it's like a part of other behavior. Clear? Tic, it's a part of other behavior. Very often, tic, this movement activity or vocal activity or mimic activity has very strong connections with stress which feel patients. For example, when patients worry about something and he won't speak something, he do some activity. Clear? For example, when you sit down and do something like this, it's not a tic. It's not a regular. It's like a stereotyped movement. Tic. It's mean accompany other type of behavior. Clear? For example, if patients relax, motor activity absent. In stereotyped movement, patients, for example, relax and do something like this. It's a stereotyped movement. Clear? Stress like a regular. It's mean every time same. Tic, every time same. Clear? Tic, every time same. Stereotyped movement, yes, same, but like involuntary. Clear? During the tic, patients feel something pleasure. He like this tick help for him like resolve stress situations. Common causes of stress, it's a Tourette syndromes, chronic tic disorders, transient tic disorders. We discuss about this. Stereotyped, repetitive, purposeless. What's different between tic and stereotyped? Stereotyped, purposeless. For example, tic like resolve stress situations. Tic help patients do something. Tic help patients resolve some situations. And stereotyped, purposeless. Who has stereotyped? Child, baby, young child. Like children very often do some purposeless movement, maybe vocalizations. It's not a tic. It's not a tic. Clear? Why? Because stress absent. And in tic, like a tic, it's very important because very often, sometimes patient has a involuntary movement like a, I don't know, like a muscles, some stretching of muscles. It's not a tic, it's not a stereotyped movement. Why? Because it's involuntary. In general, patients can control, tic can control stereotyped movement. Chorea, it's like when muscles restricted, like something like this in eyes. It's something which present and patients cannot control. Clear? Mental disorders, mental retardations, young child, autism, level mental retardations. It's a problem. It's like a problems comorbidity with stereotype movement. For example, now I show stereotype movement. I sit down and do something like this. It's stereotyped movement. I don't feel stress. It's a purposeless movement. Why it's present? Because present. Clear? Chorea. Next, problems. What is in chorea? Simple, random, irregular. You remember, stereotyped movement, regular. Tic, regular. It's like a same activity, very same. Chorea, very often not stereotype, something different in different type, in different place, have not connection with situations. And absolutely involuntary, clear, absolutely involuntary. Who has chorea? Very baby first, yes, age more than 8 months. A lot of neurological symptoms. It's maybe hypoxia or stroke, possible etiology of chorea. Now you understand. We have 3 main types of the motor activity. Now I speak about in psychiatry. First, it's a tic. What does mean tic? Usually it's a vocalizations. It's like a special phrase which we use before something. Maybe it's some kind of face expressions. Yes, like motor activity in face. But before some stress situations, like it's like a part of situation. Second type of second group of syndromes. It's stereotyped. It's a stereotyped movement. What does mean stereotyped movement? Stereotyped movement. It's a activity. It's a motor activity without connections with situations. Patient don't think about important things. Patients have not activity. He has some other activity, but he has one stereotype movement which not influence to his emotion conditions. And chorea. Chorea, it's a neurological disorder. It's an involuntary activity. Usually it's irregular, every time different, not stereotyped movement. Clear? It's maybe some activity like some stretching of muscles, some movement of some limbs. Clear? Next, dyskinesia. Slow, protracted, twisted movement and with prolonged muscle tensions. Very often dyskinesia accompany with pain. Very often dyskinesia accompany with pain. Yes, of course, dyskinesia it's maybe a result of the side effect of drugs. Usually it's a dopaminergic drugs which reduce level of the dopamine. It's maybe idiopathic, maybe due stroke, it's maybe due some neurodegenerative disorders like Wilson diseases, Huntington diseases, Parkinson diseases. I repeat once more. Dyskinesia, it's what does mean dyskinesia? It's like a low activity. It's like a long persist, long persist muscle tensions, like muscles in one positions, and this very slow activity, not permanently, but slow, clear, but slow. Yes, of course, different diagnoses with pluses in due stroke, for example. Atetoid, what does it mean? It's like a small, slow chorea. It's a irregular movement, but chorea, it's like a, it's chorea like a more, say so. It's chorea more quickly. And what's common between chorea and atetoid? Irregular. What's common between dystonia and, for example, tic? Regular. Like, but dystonia, it's like love one motions. For example, patients had tension of these muscles, and he every time rolls the head in one direction. And usually it's painful. Etiology in childhood period, in very young, small baby, before weight 8 months, and yes, of course, due some brain lesions problems like neurodegenerative disorders, maybe infections of brain, maybe some chorea and some other syndromes. Stroke, yes, of course. Synkinesis, very interesting. It's an involuntary movement associated with a specific act. For example, when you close your eyes, you have motor activity of corner of your mouth. Usually, it's a physiological. It's a physiological process. Okay, now I pay attention to the differential diagnosis between stereotyped movement and tic. First diagnostic criteria, it's a age. Yes, of course, stereotyped, usually it's a young age, it's mental retardations, it's it's a mental retardations, patients which has a lack of intelligence ability. Tic, usual it's starting in the more adult age, and usual tic has a patients which has normal level, not a lack problems of intelligent ability. Causes of symptoms: stereotyped, consistence, waxing and waning. Yeah, it's clear, I think. Trimming of movements, brief and sudden. Stereotype, rhythmic and prolonged, clear. What does it mean, tic? Tic, it's mean you patient won't say something and he do something like this with face, clear. What does mean stereotype? You speak about something and do something like this. It's a stereotype. Typical typical moments: eyes, face, and stereotyped usuals. Arms flapping, rocking, maybe legs, maybe limbs, usual limbs, yeah. Characters of movements. Stereotyped, maybe maybe tick like one part, yes, but when we speak about face, it's a very difficult. My opinion, this characteristic bilateral, because sometimes we use only one legs, maybe two legs, and every time do one leg, something like this, yes. Situations, yes, tick, provoke factors like stress, like fatigue, and stereotyped movement like existment. It's a time. Permanently use, persist, absent, yeah. Other type, comorbidity, different comorbidity. Tick, if patient has OCD or ADHD, it's usual tick. It's autistic spectrum disorders, usual it's stereotyped movements. Mental retardations, it's stereotyped. Treatment, stereotyped, use not responsibility to medications. Usually we must use behavior treatment. Tick, possible it's antipsychotic drugs and D2 receptors antagonist. Epidemiology. In school, children's very high level of motor problems. It's like not only tick, it's maybe motor as a kind of motor activity. But tick, when we speak about child with say so normal intelligence, tick it's primary problems. Yeah, it's near 25%. Now we see that diagnostic criteria of the Tourette disorders during the we are looking glass of the new classified systems DSM-5 criteria. DSM-5 now we try use it. We don't use it in every day, but all diagnoses now we see we are looking glass of the DSM-5 or IDC-11, because I think after some years we will use these classifications. What first must be present? Motor and vocal activity, yes, not only one activity. In same time during the illness. Next, wax and vein. It's clear. Next, time, because tick sometimes present short and resolve. For take diagnosis, we need wait 1 year. Only 1 year we take diagnosis to Tourette disorders. Before 1 year, it's only syndromes. Next, very important diagnostic criteria, age. You see age, yes? And next, it's not due general medical conditions, not due intoxications, clear, not due intoxications. Thank you very much for your attention. I am Professor Alexander Dvirsky. Dear colleagues, now I come back to you. Okay, today we see, okay, now something increase my picture. Okay, today we discuss about 3 topics. Today in general I want to explain some materials about psychopathology, about symptoms, syndromes, and like these things. All of these topics you meet in our MCQ. I every time upload new and new MCQ for you, and I hope you're reading answer to questions, because remember, all case without explanations, it's so difficult. Okay, thank you very much for your attentions. Goodbye. Groups which is a class, I meet you today during the class.